try and finish it in an hour. We might go a little over. So we have Jeopardy. We'll do focus Jeopardy. Our categories today are echo illusions, which will be artifacts and images. No flex zone for basically LV function and pathology. I'm drowning, which is assessment of venous congestion. The iron heart, which is pretty much all the fun in MCS. Feeling blue, which is lung ultrasound. And shock waves, which is hemodynamics. So without further ado, who wants to go first?
What is PASS? Pass.
All right, who's up? Mike, thank you for volunteering.
Oh, I don't think so. Go ahead, Alok. Okay, fine. Let's do lung ultrasound. I'm sorry. Go ahead.
I was just saying, Alok, I think you're muted.
Feeling blue for 100?
Feeling blue for 100. So differential definitively ruled out by this echo. Hint, it's a lung ultrasound. Are the clips playing for you guys?
Yeah, it's playing.
So I'll give you another clue. By the way, Violet, I think you guys are muted. It's basically what you're seeing is you're seeing lung sliding and you're seeing a lot of B lines. So what's the one differential you could rule out with this ultrasound? Hello, go ahead.
Alok, you're muted.
Now you can hear me?
Yep.
All right. What is pneumothorax?
Yeah. Right. So basically what you're seeing is that there is lung sliding and it's the one thing that you can rule out. Right? Because if you are having presence of B lines, you should not be able to see a pneumothorax. And so really here we're seeing B lines. Or sorry, Rob, I don't know if you want to do this. By the way, Rob, I have this too.
Go ahead. It's fine.
Yeah, so basically, like, pulmonary edema, cancer, lymphoma, cancer, pneumonias, all these other differentials that cause any type of thickening of your interlobular septa, your lymphatic systems, your venous system. And then you can have like B prime versus B, which is just basically a difference between clean B lines, like you see all the way on the top, versus like more heterogeneous B lines, which is more B, like fibrosis or pneumonia. The one thing that it definitely excludes is either a normal lung, like a dry lung, or a pneumothorax. So you cannot have B lines. You cannot have a pneumothorax if you see B lines.
Right. So it's technically it's just termed like interstitial syndrome because it accompanies a bunch of different differentials, and then you can have up to 3 and still be normal pathology.
All right, Alok, you're up.
Let's do feeling blue for 200.
Feeling blue for 200. This echo finding definitively diagnoses this pathology. So name the echo finding and then name the pathology.
Syed.
So it could be a lung point with a pneumothorax.
Awesome job, man. Yeah, so exactly, right? So I don't know if you want to go, Rob.
Yeah, so exactly what we pointed out. So with that M mode, you're looking for lung sliding, and then at the transition point where you have absence of lung sliding. And then utilizing M mode, you can further confirm your suspicion. And then you're looking for what is called the barcode sign. So basically, you're seeing no movement of that pleural sliding.
And if you can capture this, it is 100%. Good job, Syed. You're up.
We'll do no flex zone 200.
No flex zone 200. The likely pathology present in this patient's echo. Syed.
So you're not seeing a lot of apical wall motion on the LV. There's good movement of the, I'm just thinking out loud.
I wasn't sure if you raised your hand. I saw a hand raised. So I wasn't sure if that was the old one or the new one.
It was the old one, but I mean, that's fine. So not a lot of apical wall motion. Would this be stress cardiomyopathy or Takotsubo?
Right on, man.
Good job.
Right, so basically Takotsubo cardiomyopathy or stress cardiomyopathy is that classic finding where you see this apical ballooning, and the more basal segments or the mid-ventricular segments are more hyperdynamic, named really after that Japanese octopus pot. So that's kind of where the name came from. And you kind of see this like, you see the spherical shape, profound thing. Now there's many different types, like more ventricular or more distal, but really to keep the shape, you should be able to always remember that pathology. A lot of hemodynamic implications. All right, Slide, you're up on roll, man.
No flex zone for 100.
No flex zone 100. This ejection fraction category describes this echo.
Hello.
Oh, wait, I need to play. What is less than 40%? Do you want an actual number on how much?
Yeah, try again. Try a category actually. Like
A category?
so
Half ref?
try being a little more specific. Like do a range. You're close.
Let's say 20% plus minus.
He said a range like 25
And
to
20%.
30.
Or you can do categories, right? So, like severely reduced, moderately reduced, mildly reduced, normal, hyperdynamic.
Severely reduced.
Anyone else want to give it a try?
Say moderately reduced.
Can you guys hear the sound effects?
I don't
Solid
know.
job,
Sound
right?
effects.
So
Can you hear me?
hopefully you can see, but
Yeah, we can
really
hear
to differentiate is like the way a lot of people have different clues on how to do it. But one way to do it is to try and think of your sticking your finger through the left ventricle and seeing how much of that space actually contracts, right? So hyperdynamic, those walls are going to be kissing, versus something that's severely reduced is not going to be moving at all. And really, like, we talk about from an intensive care perspective that all of this really doesn't matter. What really matters is the cardiac output. A patient's propensity to have decreased cardiac output is significantly higher with something that's severely reduced. Someone who's severely reduced can still have an okay cardiac output if their heart rate's fast enough, right? So this is kind of like a global assessment, and the only way to get better at this is to keep assessing it, or use things like M mode, right? So if I put an M mode through these walls, then I can see how much of diameter is decreasing from diastole to systole, and then I can get an exact percentage. And there's multiple other ways. No one way is the best way. The best one that we have is either 3D or imaging, which is a whole topic on the lecture. But once again, not very relevant to us and not really even tested on critical care echo board because ejection fraction isn't that relevant to us. Solid job, San. You're up.
Echo illusions for 100.
Echo illusions for 100. So this probe motion can be performed to switch between these two views.
Hello.
I'm sorry. Take it back. I was gonna say no need to return, but that's wrong. Oh, someone else go.
What's up, Stan?
Wait, is it a fanning motion? Like fanning downward?
Right on, man.
Good job.
Right? Ultrasound 101, right? Have your cardinal ultrasound movements that you can do. You have sweeping, which is sliding it along one axis, like that long axis. You can have sliding, which is sliding it along the more transverse axis. You can have fanning or tilting, and then you can have rocking. So rocking is going against that short border, and then fanning is going against that long border. And really get comfortable with these names because this is the nomenclature used on your echo board and that they want us to use in real life, right? So if I'm, if someone is helping me obtain an ultrasound image, or you're helping a med student or a resident with ultrasound, and they're not being able to get the best view without taking over, you can help them guide them into the better image by saying like, go ahead and sweep down, or go ahead and what you're seeing this view at your mid-papillary level, you can see that fish mouth appearance, which is the mitral valve, or you can see the Mercedes Benz sign for your aortic valve. You can go more north and go see the right ventricular outflow tract.
You're up, Stan.
I'm drowning for 100.
I'm drowning 400. Is that what I heard?
I think so.
All right, so patients' hemodynamics are assessed in the ICU. Intervention that is from A to B.
Hello.
What is intubation and fluid bolus?
What is Uday's favorite word in ultrasound?
I don't know about mine, but maybe Shraddha Patel's.
Diuresis?
Yep, that's one of them.
I thought the question is what made them go from A to B. Isn't that worsening?
Yeah, what can you do to go from A to B?
You have to think of where their Doppler is, and then the transition from A to B. So what vessel is being measured.
I'll give you guys a clue. They both are portal vein Dopplers. The Doppler being put through the portal vein, the color coming towards the liver, right? So it's it's a portal vein that, and yeah. All right, you guys want the answer?
And got one
Yeah.
part of it.
I think Stanley got one of them, yeah. All right, so we have fluid removal with either diuresis or dialysis, right? So what you're seeing is portal vein Doppler, and normally, right? So it should normally be flat. You shouldn't see any congestion. So the amount of pulsatility you'll see in your vein, even if you're next to an artery, should only be about 30%. But if the vein is severely congested, meaning backflow from the atrium because of the amount of volume overload, high right atrial pressures, you'll start to see that with each heartbeat, right atrial pressure moves, and you can actually pick up the pulsatility in your vein and see about 30 to 50% as it gets to mild. More than 50% gets to moderate. You'll actually see systolic flow reversal, meaning it'll go in the other direction when it's severe enough. Basically, a sign of severely increased pressures. And the two interventions that were done to address that were diuresis and that basically ultrafiltration with dialysis. So once again, kind of showing what it looks like in real life. So normally it should look like this. Not seeing any pulsatility on the left, and then as your severity of your right atrial pressures increase, you can see it increase on the spectrum.
So the image on the prior image on the right was an improvement?
So the prior image, you go back. This is
I thought it
from
was worsening, so I'm just confused.
it's showing severe congestion, right? Because you're seeing systolic flow reversal.
Uh-huh.
A vein does not look like an artery. Versus this is what it should look like. It's normal because the vein should not have any pulsatility. So in order to go from this where you're seeing severe congestion, you took out a bunch of fluid with diuresis or dialysis, and then you to baseline. And this is how we try, or should be trying to assess our hemodynamics of venous congestion in the ICU. This is how you know that you adequately diuresis patient enough. AKA, if I see a patient with this Doppler A, I'm doing my daily ultrasounds in the patient, I am flooding with diuretics so I can get them back to here. And I'll do the same with intubation as well. So if patient's on the vent, get some fluid off so that
And then one more thing, it's a very low flow state. So when you guys are assessing it, you should, on the side, the color Doppler spectrum should be at the lowest flow setting, which you can just change. So like AUC 20 is around kind of ideal for that low flow state to help identify your portal vein.
And you'll definitely see this on your boards.
Oh, look, can you just mute the vibe board? Sorry, it's like a big echo.
That's fine. Because then we won't be able to hear them.
True.
All right, what's up?
All right, Stan, go ahead.
Or whoever.
Feeling blue 300.
The likely diagnosis in the acutely dyspneic patient. So what you're using here is you're using the blue protocol to try and make a diagnosis. So here you have your right lungs. Basically, you're scanning all the anterior points. So the right lung, the superior, and then the left lung, superior, and then both inferior. And so per the blue protocol, what will be your diagnosis? Anyone want to give it a try so I can help you guys out? Hello, go ahead.
Is it a left-sided pneumonia?
Yeah, absolutely. So you want to explain how you got there?
On the right, it looks like normal lung sliding.
Uh-huh.
On the left, I'm seeing B lines. If it was, I know you showed the image of the cardiogenic edema versus, other things. I'm not entirely confident saying it's one or the other, but if it's unilateral, I'm thinking pneumonia rather than edema.
Yeah.
Exactly. You're seeing A lines on the right side, which is pretty normal, right? And then you have unilateral interstitial syndrome. So typically cardiogenic pulmonary edema would be bilateral. And then left side, you got to think of other just unilateral stuff. So pneumonia being one of them.
Yeah, absolutely right. So this is like your classic blue protocol. And so this patient would likely be an A-B profile, meaning it's A on one side and B on the other. And so if it's diffuse B, like your homogeneous ones, like there's likely some level of pulmonary edema or interstitial syndrome, versus if it's just an A profile, then you want to investigate further, because really your diagnoses that are left is pneumonia, PE, COPD, or asthma. And if it's an AB profile, very classic for if you see C profile, which is those consolidations at the lung pleura, then you can kind of make the diagnosis of pneumonia. That B prime, anything that would cause interstitial syndrome, so like ARDS, pulmonary fibrosis, pneumonia. And then if you see A profile plus a lung point, it's a pneumothorax. If you don't see the lung point, it means you can't rule out pneumothorax. It just means that you're not seeing lung sliding. And this is just kind of another neat image. I'll send these slides out so you can save them too. But when we did a lung ultrasound lecture, all this was there. There's an entire lecture online on just the blue protocol that we've done in the past. It's all recorded. But solid job, man.
How much was that for? 300?
Yep.
All right, Alok, you're up.
I think you're
Can
muted
you hear
again.
me? Okay, Alok went to cold blue.
Oh, all right. Will somebody on his behalf choose something?
Go with I'm drowning 100.
I'm drowning 100. The patient has warm lower extremity and abdominal cool upper extremities due to this pathology. I'll give you guys a clue. You're seeing the IVC.
The IBC thrombosis.
Yeah, man. Solid job. Let's go. Any guess what it could be from? So it's a IVC tumor thrombosis, likely due from renal cell carcinoma, right? Because the renal veins drain directly into the IVC. And it looks like a snake just hanging around. I think it looks more like a tongue hanging around the IVC, but cool, solid job, man. You go to the next one.
Let's do shockwaves 100.
Shockwaves 100. The likely cause of shock in this patient, which I'm sure sends a little sweat down everyone's back.
Cardiac tamponade.
Right on, man. Right,
Yeah.
so you're seeing this pleural effusion, and once again, it doesn't really matter about the size of the effusion, right? Because the size of the effusion doesn't matter. It could be a chronic effusion that's built up over time. The right side of the heart or the entire heart as a whole has had time to compensate. So how do you diagnose cardiac tamponade? Well, we know that there's various ways to assess for it. One of the things that you're looking for is right ventricular diastolic collapse, right? Because now the heart is not being able to get its preload to send out to the other side. And then because when the right side fills up, it's in pushing on the interventricular septum, pushing it over to the left, impairing diastolic filling on the left side. And you can kind of assess it, right? So you put an M mode, you see that right here. I don't know if you guys can see my marker. you can see that this is your mitral valve, and you're seeing that when it's open, meaning going towards the atrium, this is how you know that this period right here is diastole. And in diastole, when the right ventricle wall, free wall, should actually go this way, instead you see it going this way, which is pathological. So the right ventricle is not being able to fill up. Instead, during diastole, when there's a low pressure system during this period, the wall is pushed in by the higher pressure system from outside the wall, aka your tamponade. And so other things that you can look for is also, you'll see a plethoric IVC that doesn't move. You'll see that right chamber collapse. So you'll see either diastolic right ventricular collapse or systolic right atrial collapse. And then the other thing that you can look for, we kind of talked about that interventricular interdependence, right? This septum kind of bouncing a little bit. You can see variation. So you can put a jet through your mitral valve, and you can either do continuous wave Doppler, and you'll see that if you see a notable variation with inspiration or in the like a big decrease in inspiration for the mitral valve and a big increase in your tricuspid valve during inspiration would also point towards the same pathology, and that's called pulsus paradoxus. Oops. Trying to figure out how to exit the laser pointer. There we go. Nope. There we go. Want to go again?
What was that? Backways 100. Cool.
Whoever was in Vineland.
All right, let's do the Iron Heart 100.
Iron Heart 100. So this view is being used to guide insertion of this device. So name the view and name what could be being inserted right now.
Is it parasternal view?
Not exactly. So I'll give you a clue. It is, I'll give you the view, and then maybe you can try and figure out what we would use to, or when we would use this view to kind of insert a device. So it's a subcostal view. So this is your right ventricle. This is your left ventricle. At the top is your right ventricle, and at the bottom is your left ventricle. When doing this procedure, I almost always have someone take a probe and put it over there in this view so that I can avoid any delays in doing the procedure if I'm having trouble doing the procedure. All right, cool. Let's get this one.
Central line? I don't know.
So you wouldn't necessarily be inserting a central line all the way to the ventricle, right? Syed or Feba, you guys want to give it a try?
There's only a few things that we actually place into a right ventricle.
Percutaneous trend.
Sorry?
Like a pacer, percutaneous pacer.
Yeah, right on. So, right, a subcostal view to guide insertion of a TVP. You can use an apical 5 view as well, But usually if I'm having a resident kind of do this, they're going to have an easier time finding the subcostal view. Plus that subcostal view just gives me a better view of the right ventricle in more, I guess, novice hands. So yeah, you can see the reason I like the apical view is that if I'm having issues trying to float and you have massive TR, then you'll see the wire kind of curl up in the right atrium. But yeah, I mean, I think it's a great tool to, I don't know if anyone else has any experience with this, but using ultrasound when you're putting a pacer in or swan in, especially as you're trying to float that balloon in, makes a big difference. Kind of visualize in real time where exactly things may not be going well. Want to go again?
I think let someone else go.
We can do iron heart 200.
Iron heart 200. So the measurement being taken in this image. I know everyone knows this one. What are we trying to measure in this image? The parasternal long view, there's a device in place.
So this is an impella, looks like, I would guess. And the distance between, I don't know where the railroad track signs are to the aortic valve.
Yeah, right on. Solid job.
Yeah.
Right. So you're
On the
trying to
boards as
measure.
well.
Yeah. You know, the distance from the impella inflow port, which is that shiny little thing that you see at the end of the catheter, to the aortic valve annulus. And then, Sveva, since you got this one right, you get first dibs at the daily double. What is the ideal distance for an impella CP?
That's perfect because I don't remember, but I'm gonna say 7 centimeters. Not should be millimeters. I don't know. I don't remember.
No worries. Anyone else want to give it a try? 7 centimeters would be a little too far, and you would see it hitting into the left ventricle, if not perforating it, and then you could cause profound suction events because you're not getting any flow because it's just jammed into the left ventricle.
3.5 centimeters beyond the aortic valve.
Yeah, right on.
Exactly. 3.5 to 4 centimeters, ideal spot for a CP.
Yeah, and so it varies, right? Like with the Impella 5, it can be a little longer, so you can go up to 5 centimeters. I'm sorry, it's like, I think 4 to 5 centimeters, right?
Yeah, 4.5 to 5 centimeters of the impella, the larger impella.
The 2.5 and the CP, or the cardiac power, which is like more like a 4.3 in terms of cardiac output, 3.5 to 4 centimeters. Important numbers to know when you're managing these patients and these depressions.
Which one was more than 4 centimeters?
The
So
5.5.
4.5 is the 5.5. Like 4.5 to 5 centimeters.
Okay.
And that's usually inserted axially. Yeah, graft.
All right.
Hello, since you got it, you want to go ahead and try? Or Feba?
Yeah, probably got it right.
Let's do feeling blue for 400.
Feeling blue for 400. This echo finding helps to diagnose this pathology. So name the echo finding and name the pathology.
I think Alok raised his hand first.
What is hepatization? Pathology would be ARDS or pneumonia.
Close. Not wrong, actually.
No, he's not wrong. There's a specific name for it.
Beba, what did you want to say?
It was going to be the same hepatization and then consolidative. If you just go on.
Do you guys see any other findings that could help support you? So you're right, it is a pneumonia. Do you guys see any other findings that could kind of support your diagnosis? I don't know if it's clear enough.
I think what you're probably going
get
for is an
the-
air bronchogram, but I don't
Yeah.
quite see it.
Yep,
on the-
exactly.
yeah.
Yeah, so all that
But
white
we-
speculation is all air bronchograms. And there's two types, there's static and dynamic.
And so the dynamic air bronchograms definitely is supportive of a pneumonia. Versus static, it could be either pneumonia or atelectasis. And then there are other things that you could use to kind of rule in one or the other, such as color flow Doppler. Great job, guys. Hello?
I'll give that to Feba.
I will do shock waves for 200.
Shock waves for 200. The likely cause of shock in this patient. Hint, hint, use the numbers.
Loke raised his hand.
What is septic shock or distributive shock?
Right on. And how'd you get there?
The increased VTI.
Yeah, right on. So right, like your normal VTI 17, 19 is normal, but really you're trying to assess your cardiac output. Now, the way you measure your cardiac output is your heart rate times your stroke volume. And so your stroke volume is equal to the diameter multiplied by the amount of flow that's going through it, right? So, and that can be measured using your LVOT VTI. Keeping in mind that your diameter really doesn't change that much. So you can kind of just use the VTI by itself in most scenarios, unless you have like valvular pathologies and things like that. But if you want to measure your cardiac output, you can see that, you're normally around like 5 to 7. This one's is pretty high. So only really in distributive shock are you going to get a significantly higher cardiac output. There's a lot of pearls regarding like how to measure the LVOT VTI, how to make sure it's accurate. But I really like this infographic on, how you can help identify which is the likely cause of the shock. So in hypovolemic, cardiogenic, obstructive, your stroke volume is going to be decreased, right? Even if it's due to RV failure in the setting of obstructive shock. And so those will have lower VTIs versus someone who's distributive, their heart's trying to compensate. So you'll have a higher VTI. Great job, man. Hello, you're on a roll. Feeling blue 500?
Oh, good.
This pathology shown in this POCUS image of the neck. What is going on? Scanning right here.
Loke?
Are these thyroid nodules?
No.
I'll give you a clue. Patient is profoundly hypoxic and not ventilating.
It's just
Give you another clue. The one time we would probably scan the neck besides IJ placement. Besides, line placement, see one other time we should be scanning the neck.
it's definitely something that we don't do often, but we should be using more.
Alok, I think
Oh,
we
no.
talked about this. One of your past M&Ms.
Anybody want to take a guess?
Another hint.
I'll give you a big hint. You just intubated the patient and the patient is crashing.
Is that JVD? Is that right heart failure? Or tamponade?
No.
No. It's a tough one.
I don't know. What's the answer?
The esophageal intubation.
Oh.
Yeah, so what you're looking at is it's called a double track sign. And typically when you stick a probe after post intubation, you shouldn't really see any kind of air within the esophagus. So because you're aerating now the esophagus with that tube, it outlines the esophagus and you have the dual track sign. So on the left side, typically what you would see is just a single the tracheal ring, and then you have the shadowing artifact afterwards. And then when you insert the tube, because now you're aerating it, you'll see exactly the same thing. So you'll have that ring artifact with the post shadowing.
Thanks, Rob. So what I recommend everyone doing is that having the ultrasound in the room just to confirm placement, right? Just start getting practice at this so you can identify what's normal and what's abnormal. Now, don't go ahead and practice abnormal and intentionally intubate the esophagus. But where I find this very useful is that if someone is crashing and I wasn't there for the intubation, every single time, I don't trust the intubator until I scan and see myself because I wasn't there, right? I don't have any proof that they got the tube in the right place. And if they're desaturating, I want to just confirm that really quickly. I think we talked about this, is very relevant to one of your past M&Ms, where we were concerned about malpositioning of the endotracheal tube. So unless you see it going yourself.
Yeah, we used a Bronc to take a look at the time, but yeah, I know what you mean.
All right, anyone? That was a tough one.
Let's do Ironheart 300.
Ironheart 300. The name of this view and its purpose.
Dan better get this one.
Are we looking at the, oh, sorry, my bad.
Go ahead.
I didn't raise my hand. Sorry. Is this a left atrial appendage that you're looking at here?
Nope.
No? Oh, well.
Nope.
Just the bicable view.
Hello?
Bicable view?
Yes.
Yeah. And what would be just the bicable view?
You can see the two tails, I guess, from to the left and to the right more so. And then I guess that's the atrium in the middle.
Yep, so that's the right atrium. This is your right atrium right here. You guys can see the laser pointer?
Yep.
And then this is your superior vena cava, and this is your inferior vena cava. And you know that it's tilted because of your probe, you've changed it to 90 degrees. You're normally looking at it like this. and now you change it to this, that you can match your superior vena cava and inferior vena cava. And so what would be a reason I would want to see this view? Hint, hint, it's a procedure.
Cannulation.
Cannulating.
Yeah.
Exactly.
For the residents, do you want to explain why?
If I can get the slide to go to the next slide, I would be happy to.
Unclick the thing.
Yeah,
the
try
laser
that.
pointer. You're still on the laser pointer.
Well, if I click it,
No, click in, then click the laser pointer again. Does it come off of it?
oh, thanks,
There
man.
you go. Yep.
So, right, you're trying to visualize your wire going in. The last thing you want to do is insert this like gigantic 15 all the way up to like a 31-inch cannula in the wrong area. So you put the wire through, you see that it's exactly in place where it needs to be, which is either in your SVC, and depending on what type, maybe you're inserting an Avalon cannula that you wanted to go from the SVC into the IVC, you want to see that it's not like, you know, hanging out in the RV and then you accidentally perforate the RV. And so just your markers again, that's your interatrial septum, that's your SVC, that's your IVC, your right atrium is there. And so you insert your wire, you're confirming placement, and then you advance your catheter through. Just like we would with, you know, a central line where you're scanning the neck, but here you actually want to see it because it's going much deeper in and it's a larger catheter. You want to be sure that you're correct. Now, there are people that will do this without using TE at bedside to put these catheters in. And that's when you get malpositioned catheters, like you guys saw the one from early in the week. I hope everyone saw an X-ray. So when you guys are at your next spots and you guys are leading the ECMO programs there, highly advocate for TEE. And bug the people that we know now at them.
Any chance you know what the general, like, about measurement would be for the wire, I guess? The general measurement of how deep you're letting that wire travel up?
Yeah, so it really depends on the catheter you're inserting, right? If I'm just inserting a, like say I'm just putting them on V, I just want to, you know, sometimes you may just be doing fem, right? But if you're doing like femoral and IJ, you want to just put that catheter and you just want to see that wire go into the superior vena cava, because then you're going to measure, right? You're going to superior vena cava atrium junction and then the inferior vena cava right atrium junction. So if that wire goes to the right atrium, that's fine, right? And this doesn't, then I know that the catheter is in place, but I'm not going to be advancing the catheter all the way into the right atrium. I'm going to keep it at the junction. So I'm going to take that wire.
And generally, is that going to be about like 50 centimeters from femoral puncture site?
So this is the thing, right? These are all estimates prior to an ultrasound.
Right.
I don't really care the number now because now I can see the catheter correctly.
The biggest thing with it is just knowing it's not only just it's not only placement, it's positioning too, where your drainage cannula is, where the flow is directed. Because even though you have it in the atria, you may not be directing the flow appropriately, and then you're not going to have a good drainage.
Solid job, man.
How much was that for? 300?
500. No, it was for 300.
Let's keep it going. Ironheart 400.
Ironheart 400. This structure is placed within the atrium to fix congenital abnormalities. What is this structure? I've only seen it once or twice in Vineland. Primarily because if they have this, they're probably not going to be following up with us anyways. They're probably not going to be going to this hospital anyways.
A look.
Is that a mitral clip?
No.
Quite.
Oh, then it's okay, something else.
Right?
Anybody else care to guess?
Is that a Watchman?
No.
Ah, damn it.
An ASD.
So I appreciate you guessing.
Stanley said an ASD.
So you're close. It is
Close.
a device used to fix an ASD. We'll counter if you can describe the. We can if you can describe how to fix an ASD. All right. So it's a percutaneous septal disc occluder. And so, PFO, ASD, you likely have a hole. Sorry, Rob, I don't know if you want to go ahead and describe it.
You can restart. It's fine.
So, right, it's you insert it percutaneously, you go into the right atrium and then put this device through the hole that you have, right? So either a PFO or an atrial septal defect. And on both sides, basically, inflate these valves. And then because it's got these two nets on them, it shows up as this classic this classic finding on echo, which just looks like the 8 sign. And it's like the only time you'll ever see this finding. Your valves, your like mitral valve replacement will look profoundly different. Your left atrial appendage occlusion devices will look profoundly different. They all have like their pathognomonic findings that you guys should be aware of what they look like so you can identify what's going on. Want to keep it going?
What do you want next?
We'll go like 20 more minutes, then we'll call it.
Hey, I'm gonna help Jay out real fast, so I'll be back shortly.
Oh,
Yep.
Good. Ed, what do you want?
No flex zone 300.
No flex zone 300. The culprit vessel causing this perfusion defect. So you really got 3 answer choices.
Just work through it, right? It's parasternal, short axis, looking through at the papillary muscle level, and then you divide it into 4 quadrants.
I'm not entirely sure on this.
Take a guess. I mean, what are you
Nice.
seeing, right?
Yeah.
Where do you see the perfusion defect? Which area? Like maybe like 1 o'clock, 2 o'clock. Where do you see the perfusion defect? Which side of the which was not pumping
So-
well?
It would be more, at least from what I can see, maybe the septal wall.
Yeah, exactly, right. So when you try and break it down, it's likely the LAD, and the way you kind of break it down is the way I remember it is you break it down into 6 segments. So you have your anterior, your inferior, your lateral, and your septal, and then you break apart the lateral and septal into anterior and inferior. So once again, anterior, inferior, and then 2 septals and 2 laterals, and that's your 6 quadrants that you would see at the base and the mid-ventricular. And then your anterior and anteroseptal are supplied by the LAD. Your inferior and infroseptal are supplied by the right side. And then your infralateral and your anterolateral are supplied by your left circumflex. Now, obviously, there's some heterogeneity behind this. Like, some people, the inferior wall can be supplied by the left circumflex, rarely, but generally. And so in this one, where you're really seeing the perfusion defect is in the anterior part of the septum, and so likely it's the anteroseptal and the anterior wall, and you can kind of see the anterior part not perfusing well, so the answer is LAD.
The easiest way is just look at where your inferior, like your lower papillary muscle is, and that's your inferior wall. So opposite is anterior, and then don't be tricked by the other papillary because it's technically an anterior septal or anterior lateral wall.
Was that explanation clear?
Yeah, no, that was very helpful. Thank you.
Rob, you see that nice little artifact in there?
Yeah, we're not gonna talk about it right now. All right, sorry.
All right, so
What do you want?
We can do no flex 400.
No flex 400. The likely pathology present in this patient's echo.
I mean, you see LVH. There's also looks like the aortic valve looks pretty thick. I don't know if that's causing severe stenosis, which is causing the LVH.
Yeah. What type of cardiomyopathy do you see in patients with profound LVH?
I don't know.
It's a congenital abnormality.
Like hokum or
Hypertrophic cardiomyopathy.
yeah.
And so there's many different kinds. You can see the one that's like obstructed because it's clearing right at the base. You can see midventricular obstructions. You can see non-obstructive forms, which is like your majority of your patients. And then you can see apical forms, which is known as Yamagaki syndrome. One of my favorite words in medicine. And so, I think it's important to identify the type of hokum that you have because it'll kind of guide your therapeutic decisions or things you want to watch out for. Great job, man. And with that, you get awarded a daily double. You get first shot dibs at this. This was an M mode done through this patient's echo. And what pathology do you see?
Is this an LVOT obstruction?
Right on, man. Right.
Yeah.
So you're seeing systolic anterior motion of the mitral valve or a dynamic LVOTO. And so MO through that sign, what you see is that you're seeing that a lot of turbulent flow if you put on color along the anterior part of the mitral valve or along the mitral valve area. And you'll see is that if you look at, let me go ahead and just show this. So what you're seeing is that here during systole, that because there's a lot of high pressure from the left ventricle during systole when it's trying to contract out, the wall actually pushes inside. And then the mitral valve also goes inside instead of closing like it normally should. Normally this mitral valve should go this way. Instead, it's going the other way into the outflow tract because of that negative pressure gradient known as the Venturi effect. So basically the idea is that like fluid, in this case blood, is flowing through a constricted area and caused by that narrowed left ventricular outflow tract. So it'll increase the velocity and decrease in pressure. And so as that blood velocity increases through that narrowed LVOT during systole, that pressure immediately downstream of it decreases, causing that mitral valve to shift towards the area of lower pressure. And so you're not getting any heart fluid out, right? And you guys know the management for this. Increase the amount of volume in this, you open it up. Increase the afterload pressure by putting on Neo or something like that. Obviously, anything that would cause more inotropy or chronotropy would worsen this. So avoid norepinephrine, avoid epinephrine, avoid dobutamine, avoid Moronon. Great job, man. You can do the next one too. Just got a few more left, guys.
Yeah, we can keep going on no flex 500.
No flex zone 500. The likely pathology present in this patient's echo. Hopefully you guys all learned this on your echo rotations. Because everyone was studying echo during their echo rotations.
Is this E to A reversal for diastolic dysfunction?
Yeah.
Kind of throwing it out there.
Oh, man. So I guess let me ask you a little bit more harder, right? So you're seeing diastolic dysfunction. How bad is the diastolic dysfunction? Grade 1, 2, or 3?
Not one. I think 2 is like a pseudo. I'm not the best at this, but say like 2 or 3. I don't know.
It'll be 1, right? So once you see that reverse, so what you're seeing basically is it's grade 1 diastolic dysfunction. What you're seeing is that normally you're going to see, right? You'll see your E higher than your A. That's normal. It's super normal. You're physiologically pumping your heart so strong that your E, because of the high amount of volume that you need to maintain a good cardiac output. For example, if I'm exercising, right? If I'm doing all my fun cardiac, CrossFit stuff, and I need to like get a lot of blood flow, then that heart is going to have really high E. However, if I start to develop diastolic dysfunction, for example, from like, the heart constantly working against a strong afterload, like high systolic blood pressures, then I'm going to get less passive filling from E, and instead I'm going to rely more on the atrial contraction, which is the A, right? A for atrial contraction, and E is passive. So the A starts to increase. However, if I keep this up, right? For example, if I have chronically uncontrolled high blood pressure, then eventually the left atrium starts to enlarge, right? We see that pretty often. So as that left atrium starts to enlarge, that left atrium, that passive filling because of high pressure is going to start, it's going to go back to that initial pattern where you see that pseudo normalization, and then it just gets more and more severe, where E becomes even more larger and A becomes even smaller. And then the atrial contraction itself is not doing that much. And so it kind of exists on a spectrum like this.
Yeah, man.
Okay, that was that grade grading was pretty helpful with the E to A.
So
Because I'm thinking it the other way around.
this is tested on the boards. And then, the other thing is you can have somebody who's grade 2, grade 3, but that doesn't mean they're in that. So it's basically you got to think of it as pressure in that left side. So you can always have somebody from grade 3 diuresis and they go to grade 2 or 1, right? It's just how much of that left atrial pressure.
And so another great tool to assess patients when you're trying to extubate them, because grade 3 and grade 2 is reversible. If you see grade 2 or grade 3, diurese them, dialyze them, get that patient back to a grade 1 diastolic dysfunction before you try and extubate them, so you increase your chances of avoiding reintubation.
So if you're
Solid job,
a
guys.
patient like from now in the ICU, and they, anybody with some sort of even reduced either regional wall motion or concentric LVH, anybody with reduced EF, have some sort of diastolic dysfunction, just stick put your continuous wave through there and look at the E to A, and if they have like a grade 2 or grade 3, and you're diuresing them anyways, do a reassessment, and you will see the changes. So what do you want next?
We can do I'm drowning for 200.
I'm drowning 200. So RT is called an ICU patient. They're being monitored after they had a end-STEMI or STEMI. They got a cath in a couple days ago, maybe like 24 hours ago. Now they're in profound respiratory distress. What pathology do you see?
I mean, there's a pericardial effusion. Don't have, or actually, yeah, I don't know if it's focal or just concentric.
A good thought.
I'm getting a little confused by that tiny circular line around the left side. I don't know if that's just a fat pad or what's going on there.
You're talking about like around the heart?
Yeah.
There.
Yeah, that's, yeah.
What do you think that could be? So what if I said that stripe that you're seeing is the pericardial effusion?
In that case, I would say that's probably like a fat pad around the heart.
No, what I'm saying that the stripe that I pointed out that I drew that you were concerned as a fat pad.
Yeah.
Then if that's then is that.
Then that would be a pleural effusion.
Right on. Right. So it's a left pleural effusion. This was the X-ray of the patient. And so it can get tricky, right? So you're doing a subxiphoid view. It's important to not mix up your pericaudal effusion versus your pleural effusions. And one way to differentiate the two is to look for that parietal versus visceral pericardium. So you see your visceral right there, right, the heart border. And then you see
Yeah.
your parietal right there. And so then this is your pleural effusion. That's how you tell the difference.
Okay.
So now, great job, man. You earned a daily double. So, right, patient out of nowhere developed a left pleural effusion. They just had PCI done 2 days ago. So you investigate further to figure out why they would possibly have this pleural effusion, and you see this echo. And what is the problem, and what do you need to get done? What do you need to do to manage this patient? It is a absolute no miss if you are in the ICU, because time is life.
So it's just severe MR?
Yep, absolutely. So what could be causing the severe MR in a patient after an MI?
I mean, just restenosis of the stent or reocclusion of the stent, possibly. I don't know.
Remember we talked about like in med school when you study for like step 1 and stuff like that, you learn about the cardinal things that complications that after an MI that you don't want to miss.
Oh, like a papillary muscle
Rupture.
rupture.
Yep. Good job.
This is like an absolute no miss. And so what is likely happening is a posterior medial papillary muscle rupture, and they require absolute surgical repair. What you'll see happen is like you'll see intensivists call for patient to be put on MCS or sorry, put on ECMO, but like that's not what this patient needs, right? So while you're in the ICU, you can try and stabilize this patient with like, afterload reduction so that more flow goes forward. You can put them on inotropes to just avoid severe hypotension, but really all these things, even maybe put a balloon pump in, but just really buying you time. And so what's happening here is why does the posterior papillary muscle rupture more easily than the anterior? Is because it only has a single blood supply. And so if that single blood supply is your culprit vessel, then it's high amount of ischemia at that tissue, and that papillary muscle can rupture. Versus like the anterior one gets dual supply from the LAD and left circumflex. So that's your vessel. You'll see like a profound flail leaflet because of the papillary muscle rupture. And you'll see this profound eccentric jet going into your LA, causing that crazy amount of shock. This is just some more images done from TEE. And really, they require emergent papillary muscle repair. There are some other ways you can see this also is that if you just have severe heart failure in that region, then the valve can be restricted because it's not moving. And that can also cause a bit of mitral regurg, but it'll be going also in the same direction, but it won't be as severe. And so, PCI, then they got severe MR due to ischemic heart disease, blah, 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 and they really require either the repair. If the ischemic disease is so bad and there's still a candidate for reperfusion, then you would do CABG instead. But definitely a no miss. Yeah, you're calling your CT surgeon not for MCS, but for valve repair. Two more, and then we'll finish up. And I can fly through some of these too.
I'm drowning 300.
I'm drowning 300. So classified severity of the patient's pulmonary hypertension. Anyone know how to calculate pulmonary hypertension? Rob, you want to walk us through it?
Sure. So you're looking at your tricuspid regurgitant flow using pulse wave Doppler, and then you're calculating your max velocity through that valve, and then using the Bernoulli's equation, which is 4v squared, you can get the severity of the pressure, and then you're looking at your IVC diameter or another means of measuring your CVP. You add that to your right ventricular pressure, which you got from that TR max velocity, and then that's your right ventricular systolic pressure. And typically that is synonymous with your pulmonary artery pressure, systolic pulmonary pressure in settings, as long as you don't have any pulmonic valve abnormalities or regurgitation or any kind of pulmonic stenosis. So sometimes you'll see on the echoes, they'll say what your RVSP is, and that's how they measure that PA pressure.
Any questions about that? Great job, Rob. So, right, the numbers are all given to you. You can see that here the IVC is collapsing and it's initially greater than 2. So your overall estimate of your right atrial pressures using this table that you just have to memorize is either going to be 3, 8, or 15. And so, you know, it's more than 2 with more than 50% collapse. So it's around 8. And then you do 4V squared, which in this case is 4. So 4 times 16 is 44 or 64 plus 8 plus 72. And that is the concept of Bernoulli's equation, which is very relevant in many different calculations you'll do in echo. It's like half the test. Tava, you want to give one a try?
Sure. Let's do shockwaves 300.
Appreciate you guys sticking around for this. There's a lot of work to put together.
Yeah, it was pain.
Diagnosed and clinched by the Doppler images of the right heart. So what you're seeing here, and this one might actually should have been maybe a 500, but basically you're seeing a TR jet, and your TR velocity is, your max velocity is around 41, and then you're seeing a pulmonary acceleration time, which is 47. And I'll just give you guys a clue. It's called a 60-60 sign. Anyone know what a 60-60 sign is? It is 93% specific for a pulmonary emboli. And so what you're basically seeing is that you measure your max TR velocity, once again using, and then you can get your jet gradient using 4V squared, and it should be less than 60. And then you should also measure your pulmonary acceleration time, which is a measure of basically pulmonary afterload. So if it's high amount of afterload, then your pulmonary acceleration time is going to be lower. And when you see both of those signs, less than 60 and less than 60, that's high. That's 93%, 94% specific for a pulmonary emboli. One of the best markers that you can use for a PE. Mistakes that I've made and people make is that they'll measure the RVSP less than 60, but really it's your TR gradient less than 60. So just the 4V squared without any measurement of right atrial pressures. I think we don't see this as much being used just because it's hard to get that pulmonary acceleration time. But this is all to say that we should absolutely be using echo to diagnose PE, even when you don't see a clot.
So just for frame of reference, acceleration time, it's just a fancy way of saying of how fast that jet gets to its max velocity.
Are you measuring the peak height distance, or are we measuring around the curve, the range of the curve?
For which one, the TR velocity or the acceleration time?
For both, actually.
Yes, your TR velocity.
Yeah, velocity is measuring the peak, but it can be tricky. Depends on it's beyond. It's just like you're normally measuring peak, but you can also use like the part where it kind of decelerates for like your diastolic pulmonary pressures, which don't worry about it.
The way I think what you see is just you're doing continuous wave Doppler. You see how this velocity is all grayed in. So in that line where you have your continuous wave Doppler going, it's just finding in that line where the max velocity is, and you can assume that your max velocity of any movement of any blood flow is going to be the TR jet. And so when you see this TR jet, you're just measuring this max velocity, which is that line, which is TR max. And it's basically the bottom of it. And that's your you can see the axis on the right and you can measure your V, and then you just do 4V squared, and that's your pressure. And then for your pulmonary acceleration time, you're measuring the distance, the time on the x-axis from the start to the peak. You're not actually measuring the height of the peak, but how long it takes to get to that peak. And that's your pulmonary acceleration time. It'll be in milliseconds. And in general, less than 105, which is a question that they commonly test on, is usually indicative of elevated pulmonary arterial pressures. SUI usually goes over it like once or twice, but then we stop using it and then we forget it.
And the boards come around and it's all they test you on.
All right, unfortunately, I gotta go in like 5 minutes, so maybe what I can do is I can just run through some of these last ones. Quickly, I'm drowning 500. This is the picture that I sent out last week, the grading of this patient's venous congestion. And so what you're seeing is IVC greater than 2, no collapse, pulmonary vein Doppler, or sorry, portal vein Doppler, maybe between 30 to 50%, but not grade 3, not severe. You're seeing systolic S less than D. But the only way you can confirm on the bottom left is with tele. And then you're seeing a renal vein Doppler on the bottom right. And once again, you're seeing, S and then D, which you shouldn't see, right? It should be flat. So this patient likely has grade 1 venous congestion, even though it looks severe, it's not. And the way you can kind of tell is that you look at the severity, the pulsatility of each one. So we kind of talked about this, right? Like, and this, we have an entire lecture on this online too, but this is just like looking at the left column, S less than D, and then as it becomes more severe going along the right, you see that systolic flow reversal in the hepatic vein. We already talked about the portal vein, and then you can kind of see here, you're seeing that second to last one on the bottom right is what you're seeing on the renal vein Doppler, and then if it gets really severe, the S will go the other way. So it's all grade 1. Last few. Or what we can do is we can finish this up some other time. I don't know what you guys want to do.
I say we save it for another time. I like these.
All right, cool. Yeah, if we have some extra time on Monday, on Tuesday's lecture, we'll do that.
This was a lot of fun. Really helpful. Thank you for putting it together, guys.
Yeah,
Yeah, of course.
Trying to get you guys, or to teach you guys more like echo stuff, because when we were studying, we're like, holy crap, there's so much stuff, and it's just like a massive burden to try and learn it all in the last 2 months. So
All right, cool. Thanks, guys. Enjoy your weekends.
Thanks, you too. Bye.